Just a quick statement that we're providing this for informational purposes only, and this doesn't constitute legal, financial, or medical advice. If you're new to Marsden Advisors, welcome. Most of our team got our start working at EHR software companies, and we launched the MIPS Success Program in 2017 to prepare for all of these major QPB changes that were stemming out of meaningful use, PQRS, and other programs. We currently support over 200 practices nationwide, supporting over 1,400 clinicians nationwide. About 80% of those are ophthalmologists, so we have a really good expertise in this area. We're hoping that this presentation specifically on the cataract cost measure will be beneficial to you. Our team actually handles MIPS for our customers. We're kind of like a tax accountant. So we just get in to your registry EHR, set everything up for you, train you, and deal with complex issues like this cost measure. And as you can see, our scores speak for themselves. We have a very good success rate compared to the national average. Today's presentation, we'll do a brief overview of the cost category as it pertains to the cataract measure. We'll go over issues with tracking performance in this category, how to access historical data, and how to interpret that data. And we'll also go deep into the actual measure specification for this measure to go over what this is picking up. So the cost category for 2022 in traditional MIPS is weighted at 30% of your MIPS score. This is the same weight as quality. So if you've been putting a lot of effort into quality, you should take a look at this as well because it's equal in weight and contribution to your overall score. Your total cost score depends on how many measures you're picked up in. There are 23 episode-based measures. One of them is relevant to ophthalmology. There's also the total per capita cost measure, but all ophthalmologists are excluded based on your specialty. But if you're in a group and you have any non-ophthalmologists, let's say you have a PA, for example, that bills under your group, you may get picked up in this measure. And Medicare spending per beneficiary, ophthalmologists are unlikely to get picked up in this because it's based on inpatient facility stays. Once we go over how to access your QPP reports, you can see exactly which measures you're getting picked up in. Now, this is different, obviously, from the other categories where it's only based on the measures you get picked up in. So, for example, if only one cost measure can be scored, that entire measure or that score is used for your entire cost category score completely. So for any practices here that are cataract surgeons, most likely you're just going to get that one cataract surgery cost measure, which we're discussing today, and that will be worth your entire 30% of this category. If you do get picked up in multiple, so maybe you also get that TPCC measure, then it will be spread evenly across those, just like how the quality category works across multiple measures. If none of the measures can be scored, then your cost category will be reweighted to other categories, and you can see that breakdown here. This will be for practices that don't do cataract surgery or that maybe do cataract surgery but aren't meeting the case minimums, such as a retina practice. Now, the biggest issue about this category is tracking the performance. So for quality, you can go in and look at your performance rate throughout the year based on what you have in your system, and you can compare that to historical benchmarks to figure out the exact score. In this scenario, cost category, all of this data is coming from your claims data, and it's using live benchmarks. So they're calculating the benchmark as the year at the end of the year. So there's no way to estimate your cost score the way you can with quality. Further complicating that, the cost category results are not provided throughout the year for you to be able to check in. They're provided after the performance year ends. And they're also provided way too late into the following performance year to really make a difference for the current performance year. So for example, the 2021 cost reports were provided just this last August 2022. So it's really not easy to use that to identify issues that are happening right now. You're always going to be over a year delayed. And then because of COVID-19, cost scores haven't been calculated since 2019. So in the past few years, the actual beneficiary level data, which we're going to go over today, wasn't available. Like they didn't include that. This year they did decide to include that, but they are not calculating the actual score. So you can't see like what you would have scored if this hadn't been excluded, but you can see the individual patients' episodes and what's contributing to the cost score. But unfortunately, you don't know the cost score for the past year. That we don't expect that to be an issue for 2022. So when you take a look at your 2022 reports next summer, you should be able to see the cost score, benchmarking, and the beneficiary level data, unless something changes between now and the end of the submission period. And then also the costs that are attributed to you aren't only under your tax ID or NPI. They can also come from other practices and facilities, which you may not have visibility into during the year. Here's a summary of the routine cataract removal with intraocular lens or IOL implantation cost measure. This measure is looking at all of the clinically related services 60 days prior through 90 days following the cataract removal with IOL implantation. The trigger or the inclusion criteria is billing a 66984 routine cataract surgery code. It is only this code. No other cataract surgery measures are used, or no other cataract surgery codes are used to trigger this measure. The attribution, that goes to the clinician who built that trigger code. It is a case minimum of 10 episodes, and that's depending on if you're a group reporting or individual reporting. So if you're an individual reporter, it would look to see if you had 10 episodes. If you report as a group, it's looking at if your group were to report 10 episodes. The numerator is a bit complex here, and like I said, you're not going to be able to see what it was for last year, but it's the sum of the ratio of observed costs to expected payment standardized costs multiplied by the national average observed episode cost to generate a dollar figure. So the observed cost is what we're going to be able to see in the Medicare reports. That's what you actually billed and what got charged. And the expected payment standardized cost is what CMS expected this to be paid using their risk model. That ratio is then multiplied by the national average observed episode cost. So the average across everybody for that cost to generate that amount. And then that's divided by your total number of episodes to get that average amount. That will then be compared to a benchmark that would be defined by CMS if that were to be done. And then you would get a score of 0 to 10, depending on where you fall in that benchmark. Now here's an illustrative example that may help make more sense of this. So if you notice there's a trigger service, the 66984 data service. So when that happens, CMS is going to look at all of your claims from 60 days prior through 90 days after and identify if those claims have services that are clinically relevant to that surgery. You'll notice on the bottom, the other clinicians and providers that were also billed during this time frame are also picked up if clinically relevant. This could include co-management, it could be ASC and hospital facility fees, or any additional surgeries to address complications not done by you. Once we go into the actual codes that are picked up and the diagnoses, you'll see that it is possible for things that aren't really technically related to the surgery to be picked up, and that is one of the flaws in this measure, which we'll go over in more detail. Now, as we all know with cataract surgery, it's not too often that that's done on both eyes on the same day. So that does add a little complexity here. We have received clarification from CMS. This is not in the actual measure specification, but they have stated to us that if the second eye is performed within 30 days of the first, all of the costs will be attributed to a single bilateral episode. And that's pretty much the example of what I showed before on the earlier slide, where both eyes would be included, even if they're not performed on the same day, but within 30 days. And then all of the services amongst all of them would be combined into a single bilateral episode. Now, what I have an example here is if the second eye was done after 30 days from the original, that will actually trigger 2 separate unilateral episodes. And overlapping services will be included in both episodes if applicable, but CMS has stated that they will take laterality into account. We are still waiting on clarification if that also includes diagnosis laterality for like an office visit, or if it's just looking at surgical modifiers for left and right to determine if those services should be attributed to each. And we will provide updates on that clarification when available. Now, in terms of the services we're talking about here, like I mentioned before, it's 60 days prior through 90 days after the surgery. It includes cataract surgery-related office visits, complications or return to the OR, office-based diagnostic testing and procedures, or other ancillary care. And we'll go into detail of these exact services and codes. But another thing to keep in mind, like I mentioned, the cases or episodes are subgrouped, so into obviously bilateral or unilateral, since a bilateral would be more expensive than a unilateral procedure, and also ASC versus hospital based on the place of service. Now here's a look at all of the pre-trigger costs. So what this means is these are the codes that CMS is looking for that were billed within 60 days prior to the cataract surgery. As you can see, for the eye exams, E&M codes, and telehealth, it's looking at the diagnosis 1 or 2 attributed to that service code, and it's looking for age-related or other cataracts, so pretty much everything under age 25 and age 26. So if you're billing a eye exam, E&M, or telehealth code during that time frame, and you're putting that cataract surgery or that cataract diagnosis in diagnosis 1 or 2, that's indicating to CMS that this is going to be part of the cataract surgery measure. So that is one thing that we find maybe if you're actually not examining that cataract and the patient's at your group for a completely different reason, there might be some cleanup in billing to make sure additional codes that aren't relevant don't get picked up. There are some services, additional services that do not, it doesn't really matter what the diagnosis is. So that includes punctum plugs, ultrasounds, visual axis identification, corneal topography, OCTs, corneal biometry, as well as fundus and external photography. So like I said, this is not looking at the diagnosis. So if a patient's getting any of these procedures or services done 60 days prior to the cataract surgery, and it's not really related to the surgery, they're still going to get picked up in this overall episode. Post-trigger costs, and there's many more here, and we're going to go through a few different slides, are a little bit different. And keep in mind the post-trigger costs also include the actual surgery itself and anything performed on that surgery day. So like before, the eye exam, E&M, telehealth are also based on related diagnosis, but after in the post-trigger window, it's only looking at the first diagnosis, not the second one as well. And in this scenario, it expands cataracts into also obviously pseudophakia, cataract extraction status, as well as complications like endophthalmitis, retained lens fragments, or a newly occurring cystoid macular degeneration diagnosis. You'll see that the diagnoses vary between the codes, and even unlike in the pre-trigger costs, you'll see that there are post-trigger costs that are surgeries, injections, procedures, and tests that are looking specifically at certain diagnoses. And we're going to go through a few of these slides here so you can see at a high level what is being picked up. But I highly encourage you to check the qpp.cms.gov site's resource center. If you go to that area, you can look up the performance year and the cost category, and you'll see measure information forms and measure code lists. The measure code list will be an Excel file, and this will be in the service attribution tab, and you'll see in full detail what codes are used and what diagnosis codes are used. I did not include them all in here because it would be a lot of information to see, so this is just a summary. But you'll definitely want to look at that, especially when you're comparing your actual data to what is expected to be picked up. The remainder of the costs we're going over do not matter what diagnosis is billed along with it. So like I mentioned in the pre-trigger portion, if these are being billed and it really doesn't have anything to do with the cataract surgery, they will still get attributed because it's not looking at a specific diagnosis. So here we have a lot of pretty much surgeries that would happen as a result of like a complication or an issue with the surgery. There are also some retina-related measures like vitrectomy, retinal detachment repair, So, if these are relevant to the surgery, obviously they should be getting picked up. But if these are being performed at the same time, they could get picked up if it's not even related to that. And then here are some additional services such as diagnostic tests that are picked up regardless of diagnosis, which is pretty much the same as the pre-trigger with a few other items added. And like I mentioned before, I highly recommend visiting the resource library at qpp.cms.gov to see complete details of all of these codes that are included. Now, once the episode has been defined and all of the related charges have been added in, there's two more things that are done before the actual cost is determined. So first is risk adjusters. So these don't remove episodes from the measure, kind of like an exclusion does in a quality reporting measure. This just adjusts the episode cost, and it uses a few different factors. HCC codes are looked at from a look-back period of 120 days prior to the episode through the episode window, which would be 90 days after the surgery. So these are high-risk diagnosis groups based on ICD-10 codes that have been billed by any provider in that time frame. Also patient age, disability status, end-stage renal disease status, or recent use of institutional long-term care. There's also measure-specific risk adjusters. So it will look at if a patient is new versus established, or if the surgery was performed by a resident. And all of this will be in the beneficiary level data as your HCC risk score. Now, exclusions, on the other hand, actually remove the episode from the measure altogether. So this would be if patients during that look back period through 90 days, the full episode window, if they had a primary payer other than Medicare, or they're not enrolled in Medicare at any point during that period. Also, patients whose DOB cannot be identified or the main surgeon can't be identified would not be included. If the patient's death date occurred before the episode ended, if the episode was not triggered in an ASC office or hospital. There are some measure-specific exclusions, and these exclusions are pretty much the same if you're familiar with like measure 191 for cataract surgery, visual acuity. It's any significant ocular condition impacting the visual outcome of the surgery and surgery complication rate. And that's documented the same way as the HCC code. So it's looking at a look-back period of 120 days prior to the episode through the episode window. So when you're looking at this, and you're looking at your beneficiary level data, if you're noticing that you have patients showing up that are being scored that actually have a significant ocular condition or some other condition that would impact the performance, then this might be an issue where you need to be, making sure that you're billing completely and including the patient's full diagnosis history when doing these initial evaluations. All right, so accessing the historical data. So now that you understand what the measure is looking at, you can take the data from CMS and compare it to what you have to make sense of it and see if there's any issues that you can correct. So the first thing you're going to do is visit qpp.cms.gov. You'll need to log in. So if you don't have an account, you can create one. We have a blog page on our website that goes over how to create an account if you have any questions on that. Once you log in and you're associated with your practice, you're going to click on View Feedback. Located in the middle right, or you can choose the performance feedback in the menu on the left side. Then you'll choose View Practice Details. If you work with multiple practices, you'll see multiple listed here. And then choose View Group Feedback if you are group reporting, or Individual Feedback if you're individually reporting. Then scroll down to the cost category. You'll see it will be marked as NA. That is because, like I mentioned before, they did not score this category. But if you click View Details, you can see a list of which measures you would have got picked up in. And if you don't see this View Details item, that means you didn't meet the case minimum. So you didn't have 10 episodes attributed to you during this performance year. Once you identify this measure, there'll be a down arrow on the right side to expand this measure, and then you'll click the Download Episode Level Data button, and this will download a CSV file to your computer. CSV file can be opened in Excel. So what we're going to do is we're going to go through an example of an actual spreadsheet and what each column means and help decipher that. But really what you'll want to be doing each year going forward, now that we're starting to have this more consistent data available, is to access and download this data, compare the CMS data with what's in your practice management system and what you build, identify if there's any outliers, any unnecessary or unrelated visits. I know some practices might do an exam and then do a cataract eval and then do a testing visit. There might be multiple visits that are increasing your costs. So maybe there's a workflow change you need to do, or maybe there's actual coding errors. You can also identify which complications were had, especially if they didn't end up occurring at your practice. And you can take all this information and identify any issues and determine if there's any ways to improve your performance. So if I were you, I would take the CSV file that gets downloaded, put that up on, especially if 2 screens, that'd be great, put that up on 1 screen and then go into your practice management or billing system and look up these patients. Just so you understand some of these columns, entity ID is only if you're in a virtual group or an APM. TIN will be the tax ID number that the costs were attributed to, not where the service was performed or billed. So you will see when you download this for your practice, it's going to say the same TIN across the board. So if you see a service, maybe like a anesthesia, if you're like, I didn't bill the anesthesia, that's fine. This TIN is the episode triggers TIN, which is the actual surgery. You will not be able to see exactly where these other services were billed in this report, which is unfortunate, but that is what that is there. NPI will only display if you're reporting individually. So if you're running this at a group level and you want to see each doctor's individual details, you actually have to go download those individual reports. The measure ID for this will always be cost IOL1, so you don't really need to worry about that column at all. The next 3 columns, the MBI, gender, and DOB, can help you identify who the patient is. So the MBI, Medicare billing policy number, essentially. So a lot of PM systems allow you to look up a patient by policy number. So if you can, you could just copy and paste that right in and then just confirm the gender and date of birth. The HCC risk score, this is the patient's risk score for the month of the trigger episode. Then it is rescaled based on the rescaling factor for that month. So for further information on how the HCC factors into this measure, I would encourage you to check out the measure information form located at qpp.cms.gov. Expired, this column will only be present if the patient died during the year, and that date will be indicated there. And then the episode trigger date is the date of the surgery that triggered the episode. So similar to what I mentioned with the TIN, the episode trigger date is based on the surgery, not the services that you're going to see in the columns that continue off to the right. Now here's an example of a patient, and this is all of the columns that exist to the right. So everything we went over before is in the first part, and I've just cut that out to make this easier to read. What you'll see here is I have this sorted on the date of service, the episode trigger date, and you'll see that there's 2 distinct episodes, one that happened on May 25th, 2021, and another that happened on June 29th, 2021. Because the second eye was performed 30 days, more than 30 days after the first, that is why this is set up as 2 unilateral procedure episodes. One thing I will say is you can't see which subgroups are each episode is attributed to in here. I mean, we can tell from this that it is unilateral, but we can't tell if it's an ASC or hospital. Unfortunately, that's just not something that they put on here, but it's something that we have requested to help provide you more insight. So first line you can see on each episode is that facility fee, and then the next one after that is the professional fee. You can see on the first episode there was the ophthalmic biometry, an eye exam that was had an associated age-related cataract. 2 anesthesia codes were billed, and then there was 1 other office visit, and that was just for the right eye. And then you have the second episode, which pretty much has a lot of what was in the other one because it has an overlapping window plus an additional ophthalmic biometry code, which is probably for the second eye interpretation portion. So as you can see here, and what we're seeing here in these reports is that when there's two unilateral procedures that are overlapped, the costs are being factored in twice. Now, like I said, CMS has told us that they are taking laterality into account, which would make sense for something like like an IOL master, if you're indicating like which eye it was performed in. But we haven't received clarification if that also is the same for like an office visit, because an office visit you wouldn't put laterality on, but in the diagnosis it would indicate which eye. So hopefully we get additional information on that to help clarify this even more. So, but overall, you can see here, I know it looks like a lot of jargon here, but if you just focus on the service date and then in the episode service category, you'll see the trigger, and that's the actual surgery that triggered the code, that triggered the episode. Pre and post is just telling you the pre and post trigger costs. The service code column will most likely be the CPT code, so you can see 66984. For the 92136 and onward, you'll notice that there's a 3-digit code before that. That's a category level code, which you can actually see in the measure codes lists that are available on qbp.cms.gov. But if you're trying to coordinate this with what you're seeing in your billing system, you can really just ignore that part and just look at the service code. And then if there's a diagnosis that's related that gets the charge triggered into this episode, that diagnosis will also be listed here as well, along with any other diagnosis that were also billed on that visit. The service code description, this will be helpful especially if you don't understand those codes. It will show you what the service was, what the diagnosis was in full detail. I've edited these down so the screen doesn't get too busy, but you'll be able to see the full official names of the CPT, HCPCS, and diagnosis codes as well. And then the last column will be the standardized cost. So standardized cost means it's going to be the same cost applied across all practices. So it might not be exactly what you got paid because this is the national costs, because as you are aware, the costs can be varying by region, or also if the patient paid their deductible or not. So this is just a standardized amount used across the board. So I hope that information was helpful for you. And like I said, I encourage you to definitely take a look at this data and see if it matches what you expect. If there's issues that you can correct in your practice, obviously I would do that. But you might notice, like we have, that there is some information in these reports that doesn't really make sense or doesn't really align with the specifications. Like I briefly touched on before, we are reviewing the CMS provided data for our clients and providing feedback in upcoming feedback sessions that CMS offers to improve this measure and reduce those flaws. So we encourage you to do the same. We're also still getting feedback as we're going through and identifying issues. So, the information we went over today, we might have further information tomorrow, next week, next month. So I highly encourage you, if you aren't already subscribed, sign up for our newsletter at MarsdenAdvisors.com. There's a place right there where you can put your email address. We send out a monthly newsletter that includes a lot of this information. And as we find clarifications on this, we will be posting that both there, on our Twitter, and on our blogs when there's a significant change. If you are a current MIPS customer with Marsden Advisors, we will be doing this feedback report analysis for you for your 2023 performance year. Like I mentioned before, due to the fact that there hasn't been these reports and that this one was delayed, we are getting this all set up so we can monitor this for you for next year and give you some feedback as we begin 2023. If you're not yet a client and you need help with this, definitely reach out to Get Started at MarsdenAdvisors.com for details. We do have an offer. This is our only offer that we have for 2023 because we like to get started as soon as possible. The later we wait, the more work it is for us. So if you sign up for our 2023 MIPS Success Plan by the end of this year, you'll get 20% off of that plan. And you also get a complimentary review of your current 2022 submission. So before the year ends, we can set up a call with you, look at everything that you're reporting, making sure that everything was covered, there's no major issues, and if there's any hardships that you should take, we we can help guide you through that. So we won't be able to actually do a full support for you this year, but we can definitely make sure you're on the right track and then get everything set up for next year. Besides the cost report feedback, our client success managers get connected into your registry, EHR, set up measures, track measures for refinement, making sure that patients that should be meeting the measures are, and providing regular feedback to your practice. So if you're interested in that, like I said, check out Get Started at MarsdenAdvisors.com. And now that we have a few moments remaining in the webinar, we can now go over any questions you may have. If you haven't already asked the question, you can put that in the Q&A box in the Zoom app. If you're having any issues with that, you can also use the chat feature.